Welcome to today's HealthLine webinar from the American Association of Kidney Patients titled Stop the Itch, Understanding and Managing Chronic Kidney Disease-Associated Pruritus, supported by an educational donation from B4 Pharma. My name is Erin Kale, and I am AAKP Director of Patient Insights, Data Analytics, and Advocacy. I oversee our patient research and education activities, as well as our grassroots engagement and advocacy. AAKP's HealthLine webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives. We work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research, shaping the next generation of healthcare services, assistance programs, and innovative new treatments. And we encourage you to take part in our flash surveys and other engagement opportunities. On our first slide here, I'd like to point out some research that AAKP recently conducted independently to find out key insights from kidney patients with CKD-aP. Nearly 70% of in-center dialysis patients that self-identified as having moderate to severe itching had never heard of CKD-aP. Nearly 50% of respondents shared that their itch impacts their daily lives and activities, and nearly 30% reported that it impacts their mental health. Nearly 40% of respondents that experience moderate to severe itching have never discussed it with their doctor. And nearly 50% of respondents shared that their healthcare team has never discussed itching with them. So as you see, chronic kidney disease-associated pruritus is a common condition that many individuals on in-center dialysis experience, and many are not officially diagnosed with it. We developed this webinar to help increase awareness about this condition and provide you with tools to talk to your healthcare team to determine if you have CKD-aP. And thank you to all of you who shared your insights with us by completing this survey. At this time, I'd like to introduce our first guest speaker for today's webinar. Dr. Stephen Fadum is chair of AAKP's Medical Advisory Board, and he is a champion for chronic kidney disease education. He is a clinical professor of medicine, Baylor College of Medicine, section of nephrology. Dr. Fadum attended Tulane University and graduated from the University of Oklahoma College of Medicine. After he completed his internship and residency at the University of Texas Health Science Center, MD Anderson and Herman Hospitals, he did a renal fellowship at the University of Texas Health Science Center in San Antonio. Dr. Fadum was one of the first doctors to discover the value of the internet for patient education, and he founded several websites dedicated to public service and the dissemination of clinical information, including the Nephron Information Center, WikiKidney, TouchCalc, and dialysisunits.com. He has participated heavily in the development and revisions of numerous AAKP patient education materials, including the AAKP Patient Plan Series and the AAKP Kidney Beginnings, a patient's guide to living with reduced kidney function. Dr. Fadum is the recipient of the National Kidney Foundation's Distinguished Service Award, the AAKP Visionary Award, the AAK Peter Lundeen Award, the AAKP Medal of Excellence, and the President's Volunteer Service Award. Dr. Fadum is listed in America's Top Doctors, and he serves as editor of AAKP Renal Life magazine and as a historian for AAKP. Dr. Fadum, thank you so much for joining us today to share information about this common concern among individuals on hemodialysis. I'll turn things over to you.
Thank you very much. And it's a pleasure to be here with you today. And I'd like to talk about something which we don't often think about, but we really should, and that's itching. And when I started preparing for this talk, I started asking my patients if they itched, and they never had brought it up to me. And then after I started asking, they said, yes, we do, and it's a terrible problem. Thank you for asking. So this hopefully will be very valuable to you to understand more about what itching is. So the proper term is chronic kidney disease associated pruritus. We're going to try to answer 6 questions during this lecture series, during this talk. The first is, what is chronic kidney disease associated pruritus? Second, how is it diagnosed? Third, who is at risk for CKD-aP? What causes it? Will it ever go away? And finally, how do we manage it? So first, what is chronic kidney disease associated pruritus? First of all, it's an underreported comorbidity associated with kidney failure, with ESRD. And you've heard 40%, you've heard up to 70%. So when you review the entire literature, up to 90% of patients may have itching. And some of them may not even talk about it, but it may still be a problem for them. Its symptoms vary from simply scratching to having sores on your arms, but it may not be associated with skin lesions. In some patients, it is. It can cause serious infections even. And it can also be related to other diseases beside kidney disease, such as liver disease or hematologic disorders, skin conditions, or infestations from bugs or parasites, things like that. So if you do a study, a survey, this is the Dialysis Outcomes and Practice Patterns Survey that looked at itching between 1996 and 2015 in 17 countries. They looked at 35,452 patients. In 1996, 28% were really bothered with it, and the number dropped down by 2015. 17% of patients who had itching never told their health staff about it. 18% were never treated with anything. 68% of medical directors underestimated the prevalence of itching in their facilities. They never realized that itching was a problem. And then when they did, they said, well, take some Benadryl. Here's an oral antihistamine. So they put them on oral antihistamines. 45% used another drug called gabapentin or Neurontin. There's a newer one out now called Lyrica or pregabalin. And a lot of doctors thought, oh, it's just related to adequacy of dialysis or your parathyroid hormone level or your calcium or your phosphorus. And so the doctor said, well, let's treat those values and see if the itching would go away. Most of the time it didn't. So how do we diagnose it? Well, you don't have to have dialysis to be itching. You can have it way before dialysis starts. And there are 3 episodes of itching during a 2-week period, lasting a few minutes, a few times a day, that help constitute the diagnosis. But it essentially appears as a regular pattern over at least a 6-month period. And it can cause scratch marks on the skin. Who's at risk? It can occur in patients with kidney disease. And we're going to go over why in a few minutes. It can occur in men more than women. It can occur in patients with chronic kidney disease stages 3 to 5 who aren't on dialysis. It's more common in older patients. It can be associated with a low serum albumin with inflammation, with hepatitis. And there's conflicting studies. In one group of studies, they said it doesn't have anything to do with KT over V, calcium, with phosphorus, or parathyroid hormone, but other studies said that it really does. So we have conflicting information. But it is associated with heart disease and lung disease and liver disease that occur at the same time as kidney disease. Because people itch, it keeps them up at night. And 26% have a poor sleep quality. In fact, some who have a terrible time sleeping may have a higher mortality rate. If we can treat itching, we can actually improve sleeping and improve the quality of life and even cut down on mortality. So improving itching is something that we really, really need to be thinking about. Will the itching go away? It usually does come and go, and it may be alleviated by antihistamines or other medications. Usually it does go away when a patient undergoes a kidney transplant. Let's go over this it's kind of a fun slide. It's not really that complicated because we all know what the brain is, and we all know there's a spinal cord, and we know that the nerves that run up and down the spinal cord connect to the brain. And then they go out to nerve endings that are in our skin. And then there's gangs of nerves before we ever hit the spinal cord. These are called ganglia because they're gangs, and they have different names depending on their positioning. There are several kinds of fibers that carry the nerve impulses, and some of these fibers happen to be the C fibers. So what happens is you have your skin, the epidermis, the dermis, and the subcutaneous levels, and you have something which is aggravating the skin. It can be a mineral like calcium or magnesium or phosphorus. It can be a little bit of a more complicated product like a polypeptide, which is a group of amino acids. It can be an inflammatory cell like the eosinophils, or it can be an inflammatory protein, let's say a C-reactive protein. So these will stimulate an activator. Now the activators are inside the skin, and they go and they trigger a receptor. In other words, they each have a switch that they turn on and turn off. So you can have histamines and prostaglandins, neuropeptides, proteases, and cytokines. All of these $10 words, all they do is they mean that the things that are bothering you, these minerals, have to go through some sort of activation process before they hit the nerves. And once they hit the nerves, they turn on a signal in the nerve, and that nerve sends an electrical impulse up to the brain. Okay, everything has a receptor. These receptors are universal. They go back maybe 1 billion years, 2 billion years, even bacteria, all kinds of little things have receptors on them. So they've developed and they know what they're doing. So something aggravates that receptor and it turns on, it's a tube, and it turns on a stimulus that can move energy around in the form of phosphorus, and it can send a signal. It sends signals all over the place. It can send them to the cytochrome area that cause the cells to commit suicide. It sends them to the genes that cause the cells to make new proteins to solve the problem. Or it could just send them to some nerve through a calcium channel. But anyway, they're formed by hormones like cytokines, interleukins, which are intermediates to inflammation, or stress. Stress can stimulate the substance P, and that can stimulate a receptor that can cause a stimulus too. So you can just be stressed out. and that can make you want to itch. So what's turning on this itching? We call something which turns on an itch a puritogen. So it's a puritogen, and the puritogen turns on the itching. It's just a fascinating and fun way to say turning on an itch. So the activation has to go through a receptor. So we call the receptor a G receptor. And we call it a G receptor because it turns on a G protein, guanidine. Now, guanidines, they go back to bacteria. They go back to DNA because there's adenosine and guanidine. These are all the elements, the molecules that have to do with DNA. So guanidine has been there a long time, and it's got a lot of responsibilities. And one of its responsibilities is tell the brain that we're itching. So proteases, those are little things that break down proteins, and they tear a protein apart. And you've got to have them or else you'll never digest your food. So they stimulate an itch. Neuropeptidases, neuro means brain. These are enzymes. Peptidases are simply enzymes, and they turn on elements and things that occur inside not just the brain, but inside the nerves. And they have all kinds of names. And then there's ion channels. Now, a channel is like a little highway, a little warp that's inside the cell that lets little ions, little bitty elements cross in and out of the cell. Cytokines, well, you know what those are, unfortunately, since 2020, because they're the ones that grab all the headlines with COVID. Whenever we would get COVID, we would get some people would get very, very sick. And the news would talk about they would get sick because of a cytokine storm. What would happen is COVID would turn on all of these inflammatory responses called cytokines. These are little bitty hormones, and they can make you very, very sick. But when they're not making you sick, they're making you itch. So they're in the picture too. Let's take the picture of how we itch, and let's look at two more cells that come into play here. The first is the head of the neuron. This is where all the action is. And these are mast cells. These are cells inside our body, and they love to respond to anything inflammatory. So if you come up with a cold or an allergy or peanuts or pollen, it's going to stimulate an immune response. It doesn't matter what it is. It could be a wasp, a bee. No matter what it is, it'll stimulate an immune globulin called IgG. And that goes to this cell, and it turns on the cell to release a bunch of granules that have histamine in them. And the histamines go to a receptor, the histamine receptor. And that turns on the G protein, which makes the calcium signal, which sends a message to the brain saying somebody's itching down here. There's another signal. It may not be from the wasp, but it could be from something else like aspirin or an antibiotic or prostaglandins or a complement reaction that has to do with anaphylaxis. Now, instead of turning on histamine, these turn on another hormone called, or an enzyme rather, called tryptase. And they have tryptase is a protease, so they have a protease activated receptor. So everything in the cell has a receptor. This has been doing this for millions of years, and it's been doing it all across the plant and animal kingdom. Everything's got a receptor. So it turns on the receptor, and that receptor turns on the G protein. Now, what about channels? You got calcium channels, and they turn on a receptor. That turns on the G protein. Now, I don't want to leave out marijuana here. It even has its own receptor. So you have cannabinoids, and they turn on a receptor. And what they do is they'll turn off itching. So when people have medical marijuana, it's being investigated as a way of turning off itching. Now, what about the opioids? Well, if you take a bad opioid like OxyContin or fentanyl or morphine or heroin, it'll turn on the mu receptor, the morphine receptor, and that'll turn on that G protein. It'll make you itch. But there are drugs now that'll turn on another opioid receptor called the kappa receptor. And guess what they do? They turn off that itch. They turn off that receptor to slow down that G protein response so that you stop itching. So we have a new drug that can stop itching. That's exciting. That's good news. Let's look at one of our friends, red pepper. Pepper, that'll make you itch, right? So what it does, in a low dose, it can make you itch. But in a high dose, the channel says, enough is enough. I'm tired of you, Mr. Pepper, Sergeant Pepper, and I'm going to turn you off. And that's exactly what it does. And it turns the itch off, so it slows it down. The next is cannabinoids. And we may not know what the word cannabinoid is, but we do know what the word marijuana is. So marijuana will turn off itch. Now, I am not advocating that you go out and smoke marijuana, especially if you're in a state where it's illegal, like Texas. But there are research projects being done on medical marijuana that will stop itching. But until then, we have other medicines that will help us with itching. What is going on? First of all, you have 4 things related to itching that can cause it. The neuropathies. If you have a peripheral neuropathy, whether it's from kidney disease or diabetes or a vitamin deficiency, that can cause you itching. A lot of diabetic patients with itching have a terrible problem because of neuropathy. Uremic toxins, just being underdialyzed or having kidney disease, that can turn on the itch response. Opioid dysregulation can cause it. We talked about that. And the immune system with cytokines, we talked about that. So you have inflammation, allergies, those eosinophils that turn on the mast cells to release their histamine granules. You have the non-histamine-related mast cell response. You can have decreased albumin. You can have cytokines. You can have a whole lot of things that make you itch. So how do we manage itching? Well, 50% of the cases are managed by your kidney doctor, guys like me. 19% are managed by your primary care doctor, and 24% by the skin doctor. So what do the doctors do? First of all, like I said, I wouldn't be a good nephrologist if I didn't say improve dialysis, cut down on the calcium, take your Sensipar, take your vitamin D analogs, take your phosphate binders. We do that anyway, and it may not help itching. Reduce inflammation. Well, we tried that with nicotinamide, and that didn't help. What about ketofen? Ketofen is a mast cell stabilizer. It may work. Antihistamines, they work a little bit. What about just soap and hot water and emollients, just rubbing some cream on your skin? Well, because hydration helps, moisturizing the skin helps, that helps. What about ultraviolet light? Well, on a beautiful day like this, just go outside. If not, there's such a thing as phototherapy. And that will turn on a response, which will shut down itching. Back scratchers, they don't really help as much as rubbing the skin. They're a little bit overrated. What about opioid receptors? Well, difelikefalin is a new one that will help you because it will turn on the kappa receptor to shut down itching. Now in Japan, they have their own difelikefin. It's called nalfurafine, and it's approved in Japan, but not in Europe and not in America. So if you go to Japan, they have nalfurafine. There's a combination one, and I'm a little bit afraid of those because I don't like to stimulate mu receptors. And you do have an effect. It's an antagonist effect, but I don't like to mess with the morphine receptor. But it's called nalbuphine, and there's another one called butorphanol. People are doing research on it. Now, what about naloxone? That's the drug that the fireman carries with him. And if you have an overdose of heroin or something like that, the fire department will give you a shot of Narcan to try to wake you up. Well, that will be an antagonist to the kappa mu and another receptor called the delta receptor. So that does work really well at saving somebody's life if they're overdosing on heroin or something like that. It doesn't work for itching. That experiment has been tried. Now, what about pregabalin and gabapentin? Those do work, but you have to be careful because too much of those drugs can cause you to be a little bit sleepy. They can have you have sort of an out-of-body experience where you just don't feel right. So you have to be careful when you're taking too much of that. We talked about the cannabinoid receptor therapy. So those are the therapies that are now being looked at for itching. So people are not ignoring this problem. So what is out there? What's on the horizon? What's out there in the galaxy? This is our galaxy, the Milky Way. So what's out there that we need to be looking at? Okay, well, first of all, the K-opioid receptor agonist. And like I said, there's the drug from Japan that is not approved by the FDA, but it's approved in Japan. And then in the United States, we have a drug that's approved by the FDA. It's difelikefin or difelikefin, and difelikefalin is how it's pronounced, difelikefalin or difelikefalin. I've heard it pronounced both ways. And it's given intravenously. It's approved by the FDA, and it's being used in hemodialysis units. There's another one that they're using for irritable bowel syndrome, but it may work for itching. Nalbuphine has been looked at. It's being researched. It's showing promise. There is also an interleukin 31 antagonist, and it's being used for atopic dermatitis and for psoriasis. Very expensive drugs, but the interleukin antagonists do work. They are life-saving. And I've talked to people and they really say they work, but they're also very expensive. Then what about the neurokinin antagonist? They will block that substance P, and that shows a lot of promise in the elderly. That's the drug they give along with, one of the drugs they give along with chemotherapy to stop vomiting. It's also being looked at with diabetic patients who have a neuropathy because it can help with gastroparesis. So it has a lot of promise. Janus kinases, these are the inhibitors that will work on a special receptor. And the Janus kinase inhibitors work on a receptor, and they can stop signaling also. And they're having a lot of promise. Now, I want to caution you with my own black box warning. Drugs not recommended by the FDA and things that are compounded, I cannot recommend for two reasons. Number one, I can't recommend compounded agents because you never know what you're going to get from one agent to the other. and I cannot recommend off-label drugs by the that are not recommended by the FDA because, number one, I can't do it. It's illegal. And number two, even if it were legal, I wouldn't do it anyway because I think the FDA has a special purpose. They are very, very good. They will protect us. And I want to make sure that we are following their advice. What other emerging strategies? Well, there are antihistamines that they've been around for a long time, but there's a couple of new ones that are out there, and they're showing a lot of promise, but they're so new they don't even have a name yet. They're called JNG 397-58979 and ZPL 389. I tell you this because it's being researched. Another leukotriene receptor antagonist is montelukast, and that's being looked at especially topically. I wouldn't want to take it IV. It's also called Singulair. It's used for asthma and for lung problems, and it's very popular, but I would be a little bit skeptical of it being used other than topical. There's also a TRPV1 cream for atopic dermatitis. There's the pepper cream, capsaicin topical. And I will tell you, if you try this, it will burn at first, and then your body will get used to it. A lot of people use this for like muscle pain and muscle aches. They work out, they have a severe muscle ache, and they put some capsaicin on it, and it burns at first, and then it feels good later on. And then there is a topical form of cannabinoid that people are talking about that may work too. It may work on some of the cannabinoid receptors in the skin, the C1 receptors, and it's been showing some promise. And then there's just plain old analgesics like ketamine. Well, ketamine is an anti-seizure medicine. It's great orally. It's great IV. It's not great orally. It's great on the skin, but I would not take any of these types of analgesics any other way but topically. The topical capsaicin cream, they did a study in Iran, and they were able to do a double-blind crossover study in 24 hemodialysis patients. It was a very small study, but when they compared it to the placebo, they were able to show that even though there was a placebo effect, which there always is when you have itching, because there's a lot of components to itching that are just plain stress. So if you tell somebody giving you this medicine for itching, even if it's just a cream, it's going to work, even if it has no medicine in it. But what it did was it actually worked twice as good as 3 times as good as the placebo. So capsaicin does work in a very, very small study that was done in Iran. So unfortunately, the study was done a long time ago, and you haven't heard a lot about it since. Usually when a study is done in 2010, if it's really, really hot, somebody picks up on it. So there's 2 reasons why a drug like this isn't picked up. Number one, it might be that red pepper cream is so inexpensive that it's just not catching the pharmaceutical industry. And that happens. I mean, it's a very sad fact of life that once a drug becomes generic, after a while, the companies that make it, the price drops so low that they quit making it. That's happened with chemotherapy and the whole bit. It happens with a lot of medications. So there's a yin and a yang to medications, and we can't forget that. We don't get all the icing without a little bit of the cake, and we can't have the cake without the icing. There is definitely a yin and a yang to pharmacology, just like there's a yin and a yang to other things that we do. So I don't know why capsaicin didn't get any promise after 2010. It also burns initially. That may have been part of the reason. Okay, what about the leukotriene receptor antagonist, montelukast Okay, I don't, it's approved for asthma. You can get it for $10 in tablet form at Walmart for asthma, but it has a boxed warning about mental health side effects. And the last thing we need right now is more mental health problems. So I think that, I mean, maybe topically it's okay, but I am not recommending it. At least I wouldn't use it in the oral form or anything like that. Now, somebody did try it. They tried it for 30 days, and it did seem to work. And also, it decreased inflammatory markers. But the study, also from Iran, did not mention any adverse events. And my concern about research is that if it doesn't mention adverse events, that doesn't mean that adverse events aren't happening. So it may mean that there's some flaws to the study. This was done in 2017. That's already 5 years ago. So we haven't heard a whole lot since then. So for some reason, this died down too. What about opioid receptors? Well, opioid comes from the poppy, opium. And so I took this picture of a poppy plant, and this is what the poppy plant looks like. And what opioids do, they've been known for thousands of years. And what they do is they transmit signals to the brain that stop pain. So they're very useful. They were very useful for years. It's been part of the doctor's box. It may have a black box warning, but it also was in the little black bag that the country doctor took to people's homes. When they had a home injury, he would give them a shot of morphine. It's been around for a long time. It's had its bad press because it's also, you can acetylate it like you can aspirin and turn it into heroin. And it's also can be used in a moderate form to stop a cough. It can be used to stop constipation. It can be used for irritable bowel. Very valuable drug, but it's got several receptors, and 4 to be exact. And one of the receptors is the kappa receptor. So by agonizing the kappa receptor, brilliant research, you can turn off itching. Brilliant study that showed that by agonizing, by stimulating the kappa receptor, you don't have all of the bad side effects of morphine, but at the same time, you can stop itching. So we have a new drug. So opioid receptors and itching. Let's talk about this. Okay, we talked about morphine. We talked about the mu receptor, and the mu receptor is activated and it makes you not have pain, which is good. But at the same time, it can make you itch. And so we have a kappa receptor that can activate a product called arrestin. And it basically will arrest the itching. So just like if you use heroin, you will get arrested. If you use beta product, it will arrest the mu receptor in your body. It's called arrestin. And what it does, it turns off that G protein receptor and quits sending the itch signal up to the brain. And we talked about the Japanese version, nalfurafane, and we also have a version, and they did clinical trials. They've done them in the United States too, but we have difelikefalin in the United States. Difelikefalin in the United States. And it's difficult to pronounce, but luckily the trade name is Karsuva, and it's easier to pronounce. And it is a selective K-kappa opioid receptor that will block this product. This product will block itching, and it's approved by the FDA. So it's pretty exciting. With nalbuphine, They looked at that and it worked, but it did have a black box warning, and it worked and it was able to stop itching. And it was looked at in Japan with 373 patients on an 8-week study. And it was a study done by Dr. Mashur, a very fine nephrologist, a very fine doctor. It is not approved in the United States for itching. It's an anesthetic. It's called Nubain. So we want to be careful with it because it's an anesthesia, and we want to be careful because we want to stop itching, but we don't want to start something else. So even though it's been looked at overseas for itching, we have to be very careful with it. I think topically or in a very low dose, it might be okay. The difelikefalin is the one that we want to talk about, difelikefalin. And it's given in a 0.5 microgram per kilogram IV bolus, a very small amount at the age of each dialysis. It binds to proteins about 23 to 28%, about 25%. And after 2 dialysis cycles, it's out of the body. 11% is excreted in the urine in patients who have the ability to excrete it. 59% in feces, and 20% goes out in the dialysate. It can cause a little bit of dizziness and somnolence and gait problems, so it can cause falling, and that we have to be careful with it. And it can cause problems driving, so we have to be very careful with it. And we shouldn't ever take it with any other sedative. And it was approved in August of 2021 by the FDA for use in dialysis. It's a K-opioid agonist. It works. 51.9% of patients say not only do they have a decrease in itching, but it will help them sleep better. Now, the adverse events are that it can make people dizzy, can make them vomit, it can cause a little diarrhea, it can cause some somnolence, it can cause some nausea, and it can cause some falling. And that was published in the New England Journal of Medicine in January of 2020. What is our summary? How can we summarize all that we've talked about? Number one, itching is a problem, and it is caused because the things that have to do with kidney disease will activate neurons, nerves. Neuron is a fancy way to say nerve. It activates nerves that send a very complex signal up to the brain that causes up to itch. And when we itch, we want to scratch. And it's underdiagnosed. It's more common than we realize. We try a little cream for it. We try to help the patients get adequately dialyzed. We try a little gabapentin or pregabalin. Maybe send them to the dermatologist for a little, put them in a tanning machine or give them a little phototherapy. In Japan, they're trying the nalfurafine. In America, we're trying difelikefalin, and that's the drug that's been approved by the FDA. And then the other thing is, if the patients are fortunate enough to get a kidney transplant, that too can help the itching. Well, I would like to thank you very much, and I will be available to help answer questions. Thank you so much.
Thank you so much, Dr. Fadum, for providing this information about CKD-associated pruritus. Now I would like to introduce Tiffany Fisher. Hypertension runs in Tiffany's family, and her mom experienced kidney failure, went on dialysis, and eventually received a kidney transplant. When in her mid-20s, Tiffany was diagnosed with hypertension. She had it under control, but then began experiencing swelling and had an open sore on her leg. She went to the ER and learned she had kidney failure due to hypertension, resulting in a chest catheter, and 2 days later, starting dialysis at the hospital. In February of this year, Tiffany received a kidney transplant from a donor who was on life support. Tiffany is a mom of 4 and is looking forward to going back to work full-time after recovering from her transplant. She enjoys visiting with and helping fellow patients who are on dialysis at a clinic near her home. Tiffany is an active AAKP member, and we are so pleased to have her on today's webinar to share her journey. Tiffany, I'll turn things over to you.
Hi, Erin. Thank you for having me. Like you said, I did go through a journey with my diet, and as soon as I was like in center, I started experiencing the itching. It was so bad that I was at a point to taking Benadryl. Every treatment, I was taking Benadryl just to go to sleep. It never relieved the itching. It just made me go to sleep. But when I woke up, I was itching probably more worse than what I was before I went to sleep. My nephrologist at the time had prescribed me various medications like orals for the itching, but none of them ever really just worked. So basically, I suffered with itching for. They told me that if it was an allergic reaction, that it wasn't severe enough for me to be looked at or to change my dialysis. So that was never addressed. None of CKD was never brought up to me. Never mentioned. Never. I was never told about it. I never knew anything about it until um, the survey I did with you guys. Um, Basically, and that is how I dealt with my itching during dialysis. Basically, it was just Benadryl, and for the most part, when I got off of dialysis within hours, the itching was not a problem. I was diagnosed with eczema later on, later in years, but that does not even itch as much as compared to the uh, the itching I was on dialysis, on the machine anyway. Like you said, I did receive a kidney in February of this year, and for the first couple of weeks, I had no itching at all. No type of symptoms of itching. Even I had to take dialysis twice after I received my kidney, and there was no itching during those sessions, and they were at least 2 hours to 3 hours long a piece. There was no itching, so I was like, okay, well, maybe it's gone away. Um, but after they start dialing down the steroids, is when my eczema came back. But it's not, like I said, the itching is not as near as bad as it was on dialysis. Um, and basically, that is my story is with CKD, knowing CKD anyway, of it. Like I said, I was never formally diagnosed with it. I didn't have a clue about it or what it was until now, recently. Um, and my journey with it, with itching still, is I'm just seeking out uh, and solutions to help other people with it, because I do know patients who are still on dialysis that are experiencing the itching and don't have a diagnosis or receiving any type of information. They're just basically like I was, living with it.
Thank you so much, Tiffany, for sharing your journey with us. We appreciate everything that you've been doing as an advocate for others, and thank you for being on here and helping to educate and raise awareness about this condition. We will now take a few questions that individuals sent in when they registered for the webinar. And my first question here is for Dr. Fadum. And apologies, but some of this will probably be repetitive answers that you've already shared within your presentation, but I think it would be good to share again. So Dr. Fadum, what is the best way to diagnose the cause of an itch in a kidney patient?
Okay, that is a very, very good question. And it's usually a disease of exclusion. In other words, when somebody itches, the doctors want to find out exactly what caused it. Is it because of the fact that they're a dialysis patient? Is it because they're allergic to something? Are they allergic to a soap that they're using? Are they allergic to, do they have liver disease? Do they have a hematologic disorder? So the doctor always should not just say, oh, this is kidney disease. They should always try to find out why people itch. Now, once you do find out why people itch, then if they're on dialysis or they have chronic kidney disease, then what you have to do is you have to find out, okay, they're itching. We know it's kidney disease. We know it's annoying them. How are we going to treat it? And we try the usual things, making sure that they're well dialyzed and their laboratory values are normal. That we should do anyway. Emollients, the creams that people should use. Well, of course, we want to keep the skin nice and moist. A little sunshine probably is not going to hurt. But then we get to the point where we have to use medications. And it's been very, very popular to give people Neurontin, which is gabapentin is the real name for it. I don't want to use brand names if possible. The other is pregabalin. The brand name for that, of course, is Lyrica. But what we want to do is we want to see if those drugs don't work and the patient still is miserable, then we have to look at one of these newer drugs that has just come out. So that's the spectrum of how we go from you tell your doctor you're itching to the point where the doctor evaluates it. Now, the take-home message from this talk is that most patients don't tell their doctors that they're having an itch problem, and most doctors don't even think about it. So if you learn one thing from this talk, one thing only, tell your doctor when you're in dialysis or you're in your doctor's office with chronic kidney disease, tell your doctor, say, in addition to this, in addition to that, I'm itching. I have an itching problem. Let your doctor know so your doctor will be aware of that.
Thank you, Dr. Payton. That's a really important point to make. And I'd like to bring Tiffany on back to us, as I was wondering if she could share her suggestions for telling somebody, if they're experiencing itching while they're on dialysis, what suggestions would you have, Tiffany, for how they can talk to their nurse or their doctor about it?
Well, in my case, it was just very visible. I didn't have to like verbally. I did have to tell my neurologist. I did tell the nurses. I did tell, but they could visibly see me having struggling with the itching. Like mine was very severe. Like it always felt like something was biting me, or it was just a deep itch. But I do encourage people, if no one notices or no one asks you, to definitely speak up and say something.
Mhm. Thank you, Tiffany. I've heard from other individuals that the itch is almost like it's inside their body and they can't,
It
they can't scratch it. So is that something that you experienced?
Yes, yes, it was anywhere. It wasn't just in one localized spot. It was everywhere. Like I would move so much that the needles, the machine would be beeping, and my tech would be like frustrated with me because the itching was so bad. Like I was definitely moving around a lot, and at some time I would just not forget that I was at dialysis, but it was just throw caution to the wind and just scratch because it was itching that bad.
Wow. Wow, what an uncomfortable experience. And I'm glad you're no longer experiencing that. And it's good news that some
No.
new treatments are on the horizon for us. Well, I have another question here for Dr. Fadum, and that question is, does pruritus affect peritoneal dialysis and home hemodialysis patients as much as it does with in-center hemodialysis patients?
The answer is yes. Difelikefalin is not yet approved for peritoneal dialysis, to my knowledge. But yes, home dialysis patients, peritoneal dialysis patients, patients with chronic kidney disease, all have the irritants which can aggravate the neurons and make people itch. So the only thing which stops it is if you can stop the whole process through getting a kidney transplant. But the uremic toxins and the inflammation, which is associated with all forms of renal replacement therapy other than a transplant, can stimulate an itching. That's my understanding of it. But yes, my peritoneal dialysis patients also complain of itching.
Thank you, Dr. Fadum. And I know in your presentation you shared about the earlier stages of CKD and how individuals, before they go on dialysis, can experience itching as well. Now, one of our audience members received a transplant about 20 years ago, and they have recently developed this terrible itching. So they are wondering if this is a big concern, if this could possibly be a sign of rejection, and what they, should they talk to their healthcare team about this?
Well, evidently, the itching is restarting again, and it could be for many, many, many reasons. And it could be because the kidney is not working as well as it was, and some toxins are accumulating, or it could be that the medicines that are being used to treat the kidney are not, maybe they're more effective than they should be, and there's a secondary virus. It could be a lot of different things. So it's important whenever you have a new onset of anything, whether it's itching or anything else, sit down with your doctor and say, "Doctor, I'm having a new onset of itching. I'm itching a lot now. I didn't itch before. Look at my labs. Tell me what my labs are. Maybe it's my labs. Tell me what you think it is." And let the doctor examine you very carefully and see if you and the doctor can come up with a reason why this new itching is starting. That's a very good question, because that brings up that point that we should always be aware of a new symptom, whether it's itching or anything else. Always be aware of a new symptom.
Yeah, and that might be a good point to share, keeping a journal or a diary of what you're feeling and, when these new symptoms come on, so that you can best articulate it to your healthcare team. Dr. Fadum, I have one final question for you, and that is about food and medication. Are there different foods that affect pruritus by maybe making it worse or making it better? And the same for medications. Are there any other medications that maybe a dialysis patient would take that could affect the itching that they experience?
Well, from a food standpoint, there's a lot of research being done with food right now. And there are a lot of things about food allergies. And I know a lot of people talk about gluten allergies and how it affects your GI tract. Well, the gluten system, the allergens, they affect histamine and they affect IgE. So it could be that there's something going through the IgE system stimulating histamine that can potentiate an itch. Also, medications, they don't even need IgE. They can go directly to receptors on that mast cell, that cell we talked about, and they can stimulate, instead of histamine, tryptase. And so they'll go through the protease receptor. That there's two receptors. Remember, the histamine and the protease. They may stimulate that other receptor, and that'll do the exact same thing. It'll send a calcium signal through a C fiber right up through it goes through the spinal cord. They call it the lateral thalamic tract, spinal thalamic tract, because that's where it goes. That's the name of the highway. And it's called the spinal thalamic highway. and it goes up to an area of the brain, a little town in the brain called the thalamus. And the thalamus says, okay, I don't know what to do, but I'm going to send that signal up to the brain called the cortex. And we're going to think about it. The brain says, uh-oh, someone's itching. Let me buy a back scratcher. Or let me get those fingernails out there and make sure that I scratch real good. And then they get an infection. So the bottom line is it could be an allergen from a medicine or from a food that's stimulating something inside that mast cell that has nothing to do with uremia that's causing the itching. But the kappa receptors should stop it, because they should stop anything which stimulates an itch.
Well, thank you so much. And Tiffany, I have one final question for you. I was hoping you could share with us a little bit more about how you managed itching while you were on dialysis, if there was anything at all that you found helpful, and what you would tell other individuals who are on dialysis experiencing itching and they're just, kind of losing hope and they're not sure what they should do. Do you have any words of wisdom or hope for them?
Well, just keep your skin hydrated as much as possible. Um, like I said, I was taking Benadryl, and all it was doing was making me go to sleep, but you're not itching while you're asleep. Some of the medications that I took from my nephrologist, some of the prescriptions, they kind of helped, but not as much. They helped a little bit. They didn't like totally relieve the itching. Like I would itch maybe like 50% less, but not. Um, it was not a definite solution. So all I can tell you is to make sure when you start experiencing it to speak up and make sure your healthcare team can do something for you to try to alleviate that. Make sure you get diagnosed if possible or tested for CKD, any other, maybe it's an allergen, whatever the problem is. Make sure you speak up and get it looked at and seek some help for it.
Great. Well, thank you so much, Tiffany. We greatly appreciate you being with us to share your story, and Dr. Fadum to share the medical side of why the itch happens and what can be done to treat it. Thank you both very much. I'd
Thank
like to
you.
go ahead and close now with a few closing slides with some resources that might be of interest to you. I'll start with this slide here. If we didn't get to a question that you had during today's webinar, please reach out to us at info@aakp.org. We'll work with today's speakers to provide a response for you. We hope you have found this webinar informational. On our next slide, I'd like to share information about our membership. If you are not already a member, we encourage you to join us. We offer free membership to patients and family members, as well as living kidney donors, and you can join online or by phone. In order to receive all of the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our print magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their healthcare. We are proud to offer a variety of resources for both patients and caregivers. We are happy to share that we have a new pocket guide on chronic kidney disease associated pruritus with questions to ask your doctor and other helpful tips. By visiting our website at aakp.org and clicking on the store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download, and you can also order materials by phone. I'd like to bring your attention to our webpage dedicated to CKD-aP. From our homepage, click on our Center for Patient Research and Education, and under there you will see Related Health Conditions in the green sidebar. Click on that and then click on Chronic Kidney Disease Associated Pruritus. On that page, you will find information and resources, including a link to download that new pocket guide. And towards the bottom of the page, you will find a link to our Patient Voice, Patient Choice initiative. While we are very pleased to have shared with you information about the new FDA-approved treatment for CKD-aP that Dr. Fadem mentioned in his presentation, access to this treatment for patients on Medicare is limited. We hope you will visit AAKP's Patient Voice, Patient Choice initiative at www.patientvoicepatientchoice.org to learn more about this and how you can contact your elected officials and CMS to ensure all patients have equitable access to FDA-approved treatments. We are pleased to share that our 2022 events will take place virtually and with free registration to ensure that all can participate. Our Global Innovation Summit with George Washington University School of Medicine and Health Sciences will take place June 29th and 30th. Our National Patient Meeting will be September 21st through the 23rd, and our Policy Summit is scheduled for November 16th. We encourage you to visit our on-demand webpage where you can find educational sessions from our previous events. We also have many resources on our coronavirus resource page available at this link or by clicking on the red button from our aakp.org homepage. We'd again like to thank today's speakers, Dr. Stephen Fadem and Tiffany Fisher, for sharing information about how you can stop the itch. And thank you to V4 Pharma for supporting this educational webinar. We hope you will continue to be informed and stay safe. Thank you.